بله خیلی ممنون.
Hello everyone, it's 7 p.m. now in Iran. It's time to start the program. First, I will briefly introduce myself. I am Marjan Yaghmai, Associate Professor of Medical Genetics at Oncology, Hematology and Cell Therapy Research Institute and head of the leading house for Iran-North America Academic Partnership. We are pleased to present the 12 parts of the How I Treat series in hematology entitled How I Treat Myelodysplastic Syndrome. This program provides a unique opportunities for fellows in training and attendees to learn more from well-known expert hematologists and medical oncologists from the US. At the end, we hope the audience has gained knowledge helping to utilize current standards of care and incorporate recent advances into management of hematologic and oncologic patients. The review series was realized with help from the Oncology, Hematology and Cell Therapy Research Institute, the Appraise to Raise team, and Dr. Maziar Shadman, Associate Professor of Medical Oncology at the University of Washington, and the support of the Vice Dean for Educational Affairs of the International Campus. I would like to express my most sincere gratitude for the support and welcome to this educational program. It's a great honor for us to have you all here, at least virtually. Before we start, I would like to thank our invited speaker, Professor Dr. Mojtaba Akhtari. I'm now asking Dr. Shadman to introduce our valued guest speaker, and following that introduction, we will start the program, and Dr. Peykar, hematologist and oncologist from Isfahan University of Medical Sciences, will moderate the program. I hope you will find this webinar informative and helpful. Dr. Shadman, please.
Thank you, Dr. Yaghmai, and I would like to say hi to colleagues in Iran. It's my real pleasure to introduce Dr. Mojtaba Akhtari. Dr. Akhtari is a professor of medicine and chief of adult bone marrow and stem cell transplant at the Loma Linda University in California. Dr. Akhtari is an expert in hematologic malignancies with a focus on acute and chronic leukemias, myelodysplastic syndrome, cell therapy, and stem cell therapy. Before joining the Loma Linda program and leading the program there, he was a faculty member at the University of Nebraska, and after that, University of Southern California, where he continued his research and in heme malignancies. He's a great educator and heavily involved in research in heme malignancies, and we are so grateful for him that he accepted to teach us about myelodysplastic syndrome this morning. This morning here and this evening in Iran. Thank you very much, Dr. Akhtari. Please go ahead.
Hi, everybody, and I have to express my deep and sincere gratitude for this invitation. I did my medical training at Tehran University of Medical Sciences, and as I mentioned earlier, I feel honored. I'm going to talk about myelodysplastic syndromes, and this is interesting since we have students and residents and fellows. I felt that let's start from the beginning. So myelo means marrow, and this means irregular, and plasia proliferation in Greek. So it's interesting that myelodysplastic syndromes, these patients have usually pancytopenia, but when you perform bone marrow strand biopsy and look at the bone marrow, you see hypercellular bone marrow. So the bone marrow is busy looking, and these are obviously clonal disorders of the hematopoietic stem cell, and the bone marrow, as I mentioned, is hypercellular. They have distinct morphological, cytogenetic, and mutational abnormalities. How things started, it was the beginning of 20th century when reports of cytopenias refractory to treatment were published, and then a French hematologist called Chevalier used this term autoleukemias, and then by late 40s some hematology oncologists started using the term pre-leukemic anemias, which still is in use. And by 1953, researchers realized that these cytopenias involve not only erythroid lineage, but also myeloids and megakaryocytes. And then by 1975, the term hematopoietic dysplasia was used. I start with a case, actually, these are real cases. My patients, sorry for the typo, so it was 2014, 19-year-old young lady was found to have leukopenia and neutropenia. She had history of frequent infections. Actually, her sister died of AML at the age of 8. And by 2018, her bone marrow showed some hypocellular bone marrow with normal cytogenetics. And a year later, she developed pneumonia. She was found to have anemia, thrombocytopenia, leukemia, and neutropenia, so pancytopenia. This is her white cell count. As you see, moderate leukopenia, moderate to severe neutropenia. Her ANC was 0.5, mild anemia, and moderate to severe thrombocytopenia. Bone marrow this time was hypercellular, 90%, and it showed dysplastic or dysplastic changes in all cell lines. Cytogenetic showed 46XX. However, by FISH, she had abnormalities of chromosome 5 and 7, so monosomy 7 in 13 metaphases. This is from her peripheral blood. As you see, this is we call it a pseudo-Pelvic neutrophil, or a bilobe neutrophil, which is quite dysplastic. And in her bone marrow, you see that she has these dysplastic megakaryocytes. So they are monolobated megakaryocytes. Another patient in 2016, 52-year-old lady present with enlarged lymph nodes. She was diagnosed with non-Hodgkin lymphoma. It was a B-cell non-Hodgkin lymphoma. She underwent chemotherapy and radiation, and then she, in 2017, she received high-dose chemotherapy. She received BEAM as conditioning and underwent autologous stem cell transplant. 3 years later, she had pneumonia, ended up with respiratory failure and ICU admission. Then she had multiple infections, and gradually her CBC got worse, and she had pancytopenia. So this is one of her CBCs. As you see, severe leukopenia, severe neutropenia, mild anemia, and moderate thrombocytopenia. Bone marrow showed dysplastic changes with 15% blasts. And again, peripheral, but as you see, she has this bilobe neutrophil, which is quite dysplastic. We call it pseudo-Pelvic neutrophil. Bone marrow is showing these dysplastic megakaryocytes, bilobed and quite dysplastic. Another patient, 82 years old gentleman, he had fatigue, macrocytic anemia, some leukocytosis and monocytosis. And he had worsening fatigue and tiredness, some anemia, leukocytosis, and his spleen was enlarged, 2 centimeters below the left costal margin. We look at his CBC, leukocytosis, white cell count was more than 23,000. ANC was normal. He had mild anemia. Platelet count was mildly low. He had a good going monocytosis, and bone marrow showed hypercellular bone marrow, 70% cellularity, 6.4% blast, and the diagnosis was called CMML. And again, this is his peripheral blood, and as you see, he has blasts. I call them nastiocytes. And yeah, these cells are bad, and we need to pay attention to them. Again, you see here 2 myeloblasts with nucleoli, open chromatin, not that much cytoplasm. So who gets myelodysplastic syndrome? The majority of patients are older than 60. The incidence in US is around 4.9 per 100,000 population. And we have about 20,000 cases per year. I give you an example. For AML for 2021, the estimate is 21,000 new cases. CLL is about 22,000 cases. CML is about 5,000. Kidney cancer, about 15,000, and breast cancer, more than 330,000. So as you see, myelodysplastic syndromes and AML are not common. So sometimes we don't, since many of our colleagues do not see them on a regular basis when they are sitting in their office or clinic, on a daily basis, they see mostly like breast cancer, colon cancer. So they might not be very mindful about these conditions. And approximately about 70,000 people are living with MDS in this country, in the United States. And it's interesting that the incidence it goes up when we get older. So you need to pay attention. If you look at patients who are less than 50 years old, so it's 0.5 per 100,000. But when it gets to the patients who are 70 to 79, it's about 49 per 100,000. And in patients who are more than 89 years old, it goes up to 89 per 100,000. As you know, there is evidence that when we get older, somehow hematopoiesis changes. There is like a shortening of telomeres, and it becomes more fragile. What are the etiologic factors for MDS? Are very similar to acute myeloid leukemia. So if you get history like exposure to benzene, chemotherapy, radiation, history of Fanconi anemia, and there are familial cases of MDS too. So what are the key features in MDS? As I mentioned, you have increased marrow proliferation. You look under the microscope, the bone marrow is hypercellular. However, there is a block of differentiation, and it's probably due to this. There are a couple of I would say mechanisms underlying pathobiology, but the hypermethylation of the DNA blocks the differentiation, and we have increased marrow apoptosis. So these cells cannot. Bone marrow is hypercellular, and you have ineffective hematopoiesis. So if you follow some of these patients, like in the beginning, when even they haven't started treatment, you might realize that like their ferritin is elevated, and you might scratch your hair, your head, that why this patient has elevated ferritin level, or you might see a mildly elevated bilirubin. The total bilirubin would be elevated, and these are due to ineffective hematopoiesis, that the cells die in the bone marrow, the apoptosis in the bone marrow. It's a clonal malignant disorder, and there are not specific chromosomal changes, but you would see chromosomal abnormalities in 30 to 70% of patients, and particularly abnormalities in chromosomes 5 and 7 are common. Actually, as we know, that these have prognostic significance. So it's important when you perform bone marrow and biopsy, sending bone marrow aspirate for a conventional karyotype and FISH. What are the contributing factors that results in stem cell dysfunction and then myelodysplastic syndrome? We talk about apoptosis. There is evidence of immune dysfunction. Obviously, environmental direct toxicity. So there is increased incidence of MDS. You see it in people who work with pesticides, insecticides, epigenetic changes, stromal and angiogenetic factors, and obviously some certain mutations and DNA damage. So there is this ineffective hematopoiesis and apoptosis that obviously the dysplastic clone somehow has a clonal advantage at the hematopoietic stem cell level. And there is evidence that there is bone problem with the bone marrow environment, microenvironment. So we have altered stromal function, there are certain adhesive properties and production of cytokines. How we diagnose a patient with MDS? So you want detailed history, obviously paying attention to the patient's occupation, exposures, and family history, physical examination, looking for pallor, petechiae, purpura, and enlarged liver and spleen. You have to look at the peripheral blood smear and bone marrow, requesting Prussian blue staining to see if there are any ring sideroblasts, and obviously flow cytometry, immunophenotyping, cytogenetics, FISH, and molecular studies for mutations. You could see normal or macrocytic anemia with different size and shapes of red blood cells. We call it anisocytosis and poikilocytosis. Obviously, in these patients, B12 and folate are normal. Always check copper level. I remember that I was a fellow and a patient was referred to us for transplant because of myelodysplastic syndrome, and actually her copper level was low. Patient was taking too much zinc. There is somehow this belief in US that during winter time, if you take too much zinc, it would prevent infections. And this young lady was taking too much zinc. And as you know, there is a competition at the cellular level between copper and zinc. And if you take too much zinc, you could end up with copper deficiency. And actually, it causes dysplastic changes in the bone marrow. If you could see pseudo-Pelvic neutrophils in the peripheral blood, hypogranular neutrophils, hypersegmented neutrophils, 5 or more, obviously seeing blasts in the peripheral blood, giant platelets. And when you perform bone marrow biopsy, hypercellular bone marrow, you will see megaloblastic changes, nucleocytoplasmic asynchrony, micro or hypolobated megakaryocytes. Here I'm showing you macrocytosis. MCV is usually more than 100. Severe anemia and lots of macrocytes in a patient with myelodysplastic syndrome, a pseudo-Pelvic neutrophil. This is a hypersegmented neutrophil. So we say 5 segments or more, and the best way to define it, you should see a filament between the segments. So as you see, this patient has, let's count it, 1, 2, 3, 4, 5, 6, at least 6 segments. And as you see, the patient has anemia and macrocytosis. It's the same. This is eosinophils usually are bilobed, and as you see, this is a hypersegmented eosinophil. 1, 2, 3, 4, 5 segments in a patient with myelodysplastic syndrome. And blast, so or nastiocyte, as I mentioned, as fine chromatin, not that much cytoplasm, and you could see nucleoli. This is a giant platelet. And obviously ring sideroblasts. So always we do Prussian blue stain. Prussian blue stain would show the bone marrow, how much iron there is in the bone marrow, and then if there are ring sideroblasts. And megaloblastic changes that you would see. But what classification of MDS, you know, it has gone through different Changes. Some of you who are I am old. There was first French, American, British classification, and now we have the WHO classification in 2016. So we have, we have MDS with ring sideroblast, or and it has two subtypes. Then MDS with isolated loss of long arm of chromosome 5. These patients usually respond well to lenalidomide. Then we have refractory anemia with excess blast. Type 1 in the bone marrow, patients have 5 to 9% blast, and type 2, they have 10 to 19% blast. Then MDS, which is unclassifiable, and then refractory cytopenias of childhood. What is the differential diagnosis in a patient with MDS? Or we talk about megaloblastic anemias, B12 folate deficiency, copper deficiency, thyroid disorders. Always rule out infections. HIV patients, HCV patients. As you know, there is a distinct there is distinct change in the bone marrow in patients with HIV. We call it HIV myelopathy. Patients with hepatitis C could have dysplastic changes. Not that much with hepatitis B, but it's interesting. You see with hepatitis C, with CMV, alcohol is could play a role. These patients develop different nutritional deficiencies, and we know that it's directly toxic to the bone marrow. Exposure to heavy metals, arsenic. I don't know how is the situation in Iran, but in the US there are now, there are lots of imported herbal products from Southeast Asia, from China, and some of them actually have arsenic. So you need to, it's a urine test that would measure arsenic level. Copper deficiency, PNH is important to rule out. Severe intercurrent illness. Patients who develop, I see it on a regular basis, actually, particularly in older patients. If somebody has an acute illness or gets like a severe flu and end up in the hospital, they could develop pancytopenia. But they usually get better. Anemia of the elderly, I don't think it exists, but you have to pay attention. Obviously, medications. A good example of medications are valproic acid, Cellcept, which we use it these days commonly, particularly in patients who undergo solid organ transplant, ganciclovir, alemtuzumab, and if these changes are secondary to a drug, obviously these are reversible if you could stop the medications or reduce the dose. We have international prognostic scoring system, IPSS, and obviously now we use IPSSR, the revised one. You get online and you tap this. This was originally published by Dr. Greenberg. He is at Stanford in Blood in 1997, and it was from a group of untreated patients with myelodysplastic syndrome. And as you see, the RABT, this is based on the FAB classification. Now we use the WHO classification. So we need to do cytogenetics and FISH, as I mentioned, in IPSSR, the revised edition of the IPSS. Karyotyping is important. There are certain karyotypes such as the loss of chromosome Y or loss of the long arm of chromosome 11. It has a good prognosis, and if patients have like complex more than 3 cytogenetic changes, we call it complex abnormalities, it has a very poor prognosis. Obviously, there are monosomy 7 is not good. Abnormalities of chromosome 3, including inversion 3, and loss of the long arm of chromosome 3, they don't have good prognosis. These days, we have started doing mutation analysis. There are certain mutations which have poor prognostic significance, particularly TP53 and DNM3A. What is the natural history of MDS? So they could get infection, they could die. So mortality due to infectious causes or bleeding in 20 to 40% of patients. In about 40% of these patients, they progress to acute myeloid leukemia. And when they progress, we call it secondary AML. And as you know, secondary AML has a very poor prognosis. Out of 100 patients, if you talk about AML, all comers, at 5 years, only 26% would be alive. But if you talk about secondary AML, at 5 years, it's only less than 5% would be alive. It has a very poor prognosis, and there are new treatment modalities for these patients. So about 40% of patients progress to AML. Refractory anemia with excess blast and CMML patients, they have 30 to 50% risk of progression to AML and less than 2 years survival. So we send these patients to transplant. If a patient is transplant candidate, so it's very important to get a transplant consult and get ready for transplant. So what low risk MDS, how we treat them? So obviously this is based on the IPSS or IPSS-R. They usually have isolated anemia. If they have isolated anemia, you could use recombinant erythropoietin. For patients who have isolated 5q, you could there is data of for using lenalidomide. The first person who started using this was Dr. Azra Raza. At that time, she was at Roche. Now she's in New York, Columbia. She's a giant in MDS. Has published a book called The Cell. I really recommend it if you are interested in history of cancer, and it's a very interesting book. So there is phase 3 data about using lenalidomide. It has been published. I wonder, I have started doing IDH1 and IDH2, so that it's not FDA, they are not FDA approved in US to use IDH inhibitors, but you might be able to get it in US. I have used it actually. If a patient has ring sideroblast, there is a new drug, it's a below the skin injection called luspatercept that I'm going to talk about it. What are our goals in patients with low risk MDS? So we would like to delay disease progression, prolong survival, and improve quality of life. So low risk MDS, as you know, we don't send them to transplant. Luspatercept is a newly approved drug, so it's interesting. It's an erythroid maturation agent, and it works through the TGF beta. You could use it in most subtypes. In US, it's usually in patients who are resistant to EPO, or they lose their response to EPO. We could use luspatercept, but this drug is the most effective in MDS with ring sideroblast. There is good data behind it, and I have had patients who actually, by using this drug, they have become transfusion independent. It causes a bit of flu-like symptoms, some fatigue and tiredness, but otherwise it's well tolerated. What are the supportive care in patients with MDS? Obviously, we could transfuse them. In older patients, I always use this term, we call it personalized treatment approach. You look at the patient. If a patient has COPD and heart failure, older patient, probably the cutoff for transfusion could be for hemoglobin less than 9 or 10. Obviously, you use erythropoietin. There is data that in some patients who they lose their response to EPO, you could add GCSF actually, and they could become transfusion independent. But pay attention that we do not usually use GCSF for the treatment of neutropenia in patients with low-risk MDS. Iron chelation is important. Each bag of blood has at least 250 to 350 ml of iron. So if you continue transfusing these patients, they are going to develop iron overload and subsequent complications, such as you would have iron deposition in liver, heart, pancreas. So the iron chelation is FDA approved for low-risk MDS patients. For platelet transfusion, these patients do not usually bleed. They are different from AML patients, but in US is usually less than 10, but there is some data about even as low as 5, and they don't bleed. Do they need prophylactic antibiotics if they are neutropenic? Not really. They don't develop that much infection. If a patient is developing frequent infections, then I would use it. Otherwise, I would not use on a routine basis. We talk about loose patterns. Linolenidomide, a bit of history about linolenidomide. As you know, this is a sister drug of thalidomide, and thalidomide was produced by a German pharmaceutical company in 20th century, and for pregnant women, for nausea, vomiting, and even for sleeping, and even in Europe and Australia, it was given over the counter, and then they realized that it caused absence of limbs in newborn babies, and it got off the market. In US, it did not get approved. Actually, there was a FDA officer who refused to approve this drug because he felt that there was not enough evidence, and then so it got off the market. Then in late 90s, thalidomide came back. It showed efficacy in patients with myeloma, and then a sister drug, this second generation IMiD, lenalidomide, which was used, and now we use it in lymphomas, myelomas, and even myelofibrosis. So there is data. So it improves anemia. It's very effective in patients who have this sole abnormality 5q minus. I haven't seen that much efficacy in other subgroups of patients with MDS. It's obviously very expensive. On a separate note, I sometimes go to meetings, and you pay attention to, you've talked to like drug companies. So a 25 milligram pill of lenalidomide in US without insurance is $400. And have a guess how much it costs for Celgene. Actually, it was Celgene, is now BMS. So they buy it from an independent manufacturer for $1. This is my personal information. I found out about it during a chit chat in one meeting, but India is producing it much less. Much cheaper, and I know like some of my patients, like in US or in other, I have colleagues in other parts of the world, and they get lenalidomide from India. So that's a good source to pay attention if you want to get your hand on lenalidomide. And there is a subtype of patients with MDS. We call them hypoplastic MDS. So these patients have as I mentioned, when you look under the microscope, MDS, the bone marrow is usually hypercellular, but in patients with hypoplastic MDS, they usually have a hypercellular bone marrow, these patients respond to immunosuppressive therapy. So you could use anti-thymocyte globulin, ACG, and cyclosporine. You treat it the same as aplastic anemia. We talk about the transfusion, and so one of our goals is to shy away from transfusing patients with MDS, because there is a strong evidence that actually if you continue transfusing them, you would reduce the patient's survival. So that's a point to pay attention. What about EPO and GCSF? So there is data from Dr. Greenberg from Sweden Karolinska Institute that if the EPO is less than 500 you could actually add GCSF and it would improve the erythroid response, and they did not see actually increased risk of transformation to AML. Obviously, this is low-grade MDS, not high-grade MDS, because in MDS you are worried always that this is a myeloid malignancy, and if you add GCSF to their treatment regimen, you might stimulate the bad cells, the blasts, but they didn't report increased risk of progression to AML, and there might be a survival. I have used it personally, and it works. After a while, obviously, it loses its effects. I have even used the pegylated form. There are different. The original one was Neulasta. It's 6 milligram, but now there are biosimilars form of it as well. So what are the therapeutic modalities in patients with low-risk MDS? We talk about 5q minus. This is the sole abnormality. You could use Linolenidomide. You could use EPO and GCSF. We talk about the hypoplastic MDS. So usually the serum EPO is more than 500. They have this characteristic change. They are positive for HLA-DR15, and you could use ATG plus cyclosporine in these patients. You could use hypomethylating agents. There is, like azacitidine and decitabine for low-risk MDS. If they fail, EPO and EPO GCSF, and their EPO is more than 500. There is data phase 1 and phase 2 using 3 to 5 days of azacitidine or even decitabine for patients who failed EPO and GCSF. So, usually we use 7 days of azacitidine, but if you want to use in low-risk MDS patients, it's 3 to 5 days. We talk about IDH1 and IDH2 inhibitors. IDH1 is Tipsivo, IDH2 is IDFA. They are not FDA approved, but you might be able to use it. And for patients who show ring sideroblast Lewis Patterson. What about high-risk MDS? Before embarking on high-risk MDS, in our mind, low-risk MDS, we know what to do. We use EPO, GCSF, now luspatercept. High-risk MDS, we use azacitidine or decitabine. What about intermediate risk MDS? So that's the issue. I personally have I use IPSSR, and if I feel that these patients, look at the cytogenetics, FISH, I have more, I would say, more tendency to use hypomethylating agents in these patients. But for high risk MDS or IPSS intermediate 2 or high, so the goals are delaying transformation to AML, prolonging survival, possible cure. Cure is through a stem cell transplant, allogeneic stem cell transplant. So we have azacitidine and decitabine. We talk about that. There is evidence that the DNA and RNA gets hypermethylated. So if you could tune down this methylation, you would be able to make things better in the bone marrow. And it's not actually, it somehow you unblock differentiation and you reduce apoptosis by hypomethylating DNA and RNA in the bone marrow. So azacitidine and decitabine, they improve cytopenias. There is data about improving overall survival and delaying transformation to AML. We could use allogeneic stem cell transplant. It can cure MDS. Overall survival is disease-free survival at 3 years is 35 to 65%. The issue is that the majority of patients with MDS are older than 60 and 65. So you can't use full intensity transplant in these patients. We usually use reduced intensity. And don't forget that 75% of MDS patients are more than 60 years of age. So they are not good candidates for full intensity or myeloablative stem cell transplant. Azacitidine, it takes time. So I would call them low potency or intermediate potency chemotherapy. You need to be patient, at least 6 cycles. So 17% CR plus PR, hematologic improvement in 21%. There is overall survival data for these patients, 14 months and 17% 3-year survival in a multi-center study. And it was seen in all prognostic subgroups. Decitabine, it's an intravenous drug. No, AZA, you could do it, it's below the skin injection. You could use it as IV, but it's FDA approved for using subcutaneously. The original data for AZA was 7 days in a row, but you could people have done it 5 days, or sometimes in US, since the weekend many cancer centers and offices are closed, we bring back the patient the following week and give 2 doses on Monday and Tuesday. So that's how it's done. Decitabine is intravenous 5 days in a row, usually 20 milligram per meter square. I personally I think it's more cytotoxic. So in patients who have like RAEB2, I usually use decitabine rather than azacitidine. You know, it's more cytotoxicity. And usually well tolerated. It's 1 hour infusion. There is an oral form of it now. There are 2 drugs, decitabine and cedazuridine. So cedazuridine is an inhibitor of cytidine deaminase in the gut and liver. It has got FDA approved, but I haven't used it, and it hasn't somehow taken off in the US market. And the data is not very clear. So many people are waiting for larger studies and long-term data. But it's an oral drug. Some patients do not like to come to the office to receive an intravenous drug. So that's a good alternative. I talk about that a stem cell transplant has a role in MDS. You could cure some of these patients. So there is good data about this. I would like to switch gear and talk about therapy-related MDS and AML. So this is interesting. You know, from 2008, WHO classification lumped together treatment-related MDS and AML and called it therapy-related myeloid neoplasm, or TMN. So it's a late complication of using cytotoxic chemotherapy and radiation. It has distinct clinical, morphological, and cytogenic subsets. It has poor prognosis, and actually it opens a window for discovering mechanisms of human locomogenesis. So it's about 10 to 20% of all cases of AML, and you know, so it's interesting because as you know, for MDS, differentiating from AML is based on the blasts in the peripheral blood or bone marrow. So up to 19% is MDS. We call it like refractory anemia excess blast type 2. As soon as it's 20%, you call it AML. But these thought leaders who sat and discussed the WHO classification of 2008 and 16, they decided that it's not based on the blast in the bone marrow in these two countries. It doesn't matter. It's the history. So they have history of exposure to chemotherapy and radiation, morphology, and cytogenetic changes rather than the blasts. And you see it in breast cancer patients. Among solid cancers, number one is breast in about, I would say, 4 to 6% of patients. You could see it after lymphoproliferative disorders, lymphoma patients, particularly those who undergo autologous stem cell transplant, myeloma patients. So some of the, unfortunately, the children who get treatment for ALL get cured, but unfortunately later on they develop treatment-related MDS. And as you see, radiation, if you combine radiation and chemotherapy, is worse. So previously, many centers were using radiation and chemotherapy for autologous stem cell transplant conditioning, but then data came out that those patients who get radiation, they are more at risk for developing treatment-related MDS AML. So many centers have actually got rid of radiation as part of conditioning for autologous stem cell transplant. And it's interesting that the classification that we use for the de novo MDS, it doesn't look that it matters in treatment-related MDS. All the subtypes do worse. So that's why they say probably the pathobiology of treatment-related MDS is different from de novo MDS, and the blast count didn't matter. This is from a study Dr. Singh was working at the University of Chicago at that time. And they have both treatment-related MDS and AML, they have poor prognosis. These patients do worse. The only thing is that those who have balanced translocations, they do better. So for example, 1517, I wonder if you have seen APL, treatment-related APL, or 821 or inversion 16. Those patients who have, so the patient has a history of exposure to chemotherapy, radiation, and then those who show these balanced translocations, they do better. So it's important to pay attention to cytogenetic changes and mutation analysis. The worst outcomes belong to patients who have complex cytogenic abnormalities, more than 3, or TP53. And monosomy 5, 7, they are bad actors. Deletion of the long arm of chromosome 5 and 7, they are bad actors. So this shows you how big is the difference between treatment-related AML and de novo AML. And actually, in patients who have treatment-related AML, as a side note, because there was a discussion about how we should approach patients with AML, there is a drug is a liposomal daunorubicin and cytarabine, which is FDA approved for patients who have treatment-related AML. The data is through phase 3 data. It was shown that it was superior to 7+3. What are the features of treatment-related or therapy-related myeloneoplasms? So they have. It depends what the patients got in the past. Those patients who got alkylating agents, cyclophosphamide, melphalan, they usually develop abnormalities of chromosome 5 and 7 or complex cytogenetics. Those who get topomerase 2 inhibitors, such as doxorubicin, etoposide, idarubicin, they get abnormalities in chromosome, long arm of chromosome 11, MLL, or AML1 on the long arm of chromosome 21. These patients, interesting, the latency period is more, it's 5 to 7 years. For topomerase 2 inhibitors, is shorter. They are more similar to de novo MDS. So it's like lingering, a slowly progressing cytopenias, macrocytic anemia, and when you do perform the bone marrow biopsy, you would see lots of dysplasia in the bone marrow. They present, the topomerase 2 inhibitors, they present with like it's very acute, a white cell count of like 100,000, very similar to de novo AML. And in bone marrow, the alkylating agents, they usually have trilinear dysplasia, but they usually have monoblastic features. But prognosis, both are poor. And it's interesting that there is a strong evidence that in patients with treatment-related AML, the unfavorable cytogenetic abnormalities such as monosomy 5, monosomy 7, abnormalities of chromosome 3, and complex cytogenetic abnormalities are more common. Actually, there is a, if you look at the WHO 2016 WHO classification, there are 11 balance translocations that are common in patients with treatment-related AML. We talk about that inversion 16 and translocation 15, 17, they usually have a better prognosis compared with other subtypes. This is data from a couple of centers in US looking at the incidence of treatment-related MDS and AML after auto. University of Nebraska Medical Center, City of Hope, Dana-Farber in Boston, University of Minnesota, Cleveland, and this is from European registry. As you see, it's not that common. Like UNMC was 4% at 5 years. At City of Hope, it was 9% at 3 years. At Dana-Farber was around 9%. Minnesota 13.5% at 6 years. At Cleveland it was 6.8% at 10 years, and at BMT, at EEBMT was 8.5%. And median time was the last column shows you. It's not common, but I think it's important to pay attention. If you have patients who are your following, who have history of exposure to chemotherapy, radiation, or transplant, and they are showing cytopenias, macrocytic changes, you need to pay attention to those patients. So summary, so consider MDS in any patient with anemia or any cytopenias, particularly older patients. You need to look at the history, prior exposure to chemotherapy, radiation. I have to mention patients' autoimmune disorders that, for example, rheumatoid arthritis, they get methotrexate, azathioprine. These patients could progress could develop treatment-related MDS. You need to look at the peripheral blood smear. Don't forget, common things are common. MDS is not a common disorder. So B12 deficiency, folate deficiency, copper deficiency, alcohol consumption, HIV and HCV. For the residents and fellows, if you want to transfuse a patient, you have to order B12 folate and iron studies before transfusing the patient. Otherwise, things could get messed up. And if you order a bone marrow astronaut biopsy, do not forget cytogenetics, FISH, and mutation analysis. I would like to switch gear and I talk about, we are physicians, clinicians, we treat patients and cancer patients. This is a painting by a British painter called Luke Fieldest. If you it's in the National Gallery of Art in London, and it was painted in 1891, and it's based on a true story. The painter's son became sick, and there was this local doctor that his bedside manner impressed Mr. Mildest. The surrounding is not his house; it's a fisherman house in Cornwall, England. But I would like to, look at this is like early morning. The sun hasn't come out completely yet, and you don't see a stethoscope. It's and there you might not believe it. You could Google it. There have been papers about this painting, and the physician is sitting next to this sick boy and concerned about him, and you see his father at the background. And now we are in the era of computers. This is based on a true story. This young girl who is sitting on the bed went to see her pediatrician with her mother and two sisters, and she came out of the room and painted this. As you see, the pediatrician back is towards the patient, and he is working on his computer, and it was published later on in JAMA. So somehow we are in the era of computers, and sometimes we don't pay attention to our patient, particularly if you are running a busy clinic and patients are waiting in the waiting room, and your phone is ringing from hospital or the lab or pharmacy. But I thought that this is a quite interesting drawing. William Harvey, the master in medicine, said, as you know, medicine is an art that uses science to let us better minister to our patients. So it's better not to lose the focus. Focus is we are clinicians, and we are going to take care of our patients. I am reaching to my end of my talk, but I want to remember some of people who have touched me. I have to start with Dr. Bahman Shafaian. So I was a young medical student starting my first rotation at Amir Alam Hospital. Actually, when I got into the medical school, I was thinking about becoming a neurosurgeon. And then when I started my clinical rotations, things changed. And one of the people who impressed me in a very big way is Dr. Bahman Shafaian. So it was my first clinical rotation, and he was talking. At that time was Dr. Qadimi, Dr. Qaruni, and Dr. Shafaian. And there was this young man with AML, and he talked about AML. The intern talk about presenting the patient, and Dr. Shafaian talk, and then he went and examined the patient, mentioned that the spleen was enlarged. So at the end of the round, we dispersed, and I went back to the patient and tried to see if I could touch the spleen. I couldn't feel the spleen. So I went downstairs, knocked on Dr. Shafaian's office in the old Amir Alam building, and said, Dr. Shafaian, sorry, I tried to feel this spleen, I couldn't. And this man, is a university professor and a busy man, very kindly looked at me and said, go upstairs, I would be there in 5 minutes. And he helped me to feel my first spleen. And I have never forgotten that. Very nice man. And then the second person is Dr. Bijan Jahangiri. If I am here, it was I largely to Dr. Bijan Jahangiri. He is not a clinician, he's a pharmacologist, but he was my mentor, always encouraged me and gave me proper advice. The third one, some of you guys might know, is Dr. Freydun Allah. He is a hematologist. He is the founder of the Iranian blood transfusion service. Actually, he went around when he was a young hematologist. He just came back from England where he did his medical school and training training in hematology on a back of horse sometimes, and made the first national registry of hemophilia patients. I was interested in hematology, and I sometimes I was in touch with him when I went to England. I went to England before coming to US, and I contacted him. He was at that time he was the chief of the blood transfusion service in Bristol, UK, and he was one of my first people who wrote a recommendation letter just by talking to me on the phone and looking at my CV. And he won the World Federation of Hemophilia award last year. It's still active, and the best way, there is a Farsi Persian term, we call it, some poets have used it, like Hafiz or Jami. They call good people Ganj Ravan, a stream of treasure which is running all the time and doesn't get finished. Some of these people are the best way to describe them. And then Dr. Peyman Haddad, I know him personally. He was an oncologist, and we lost him earlier this year. I think it's important to remember Dr. Haddad and what he did for the, I would say, improvement of cancer care and radiation oncology in Iran. So I still feel sad. He was young when he died, and he would be remembered. I'm going to stop. These are my emails, my university email, my personal email, university email makhtari@llu.edu, my personal email mojtaba.akhtari@gmail.com, my office number, cell phone number. I'm more than happy to answer questions, concerns. You could, the painting, I saw it in a museum in Iran, and it's showing a physician from in the 19th century in Iran, and he's attending a sick man. So I took a photo of it. And here I'm going to stop, and I'm happy to answer your questions.
Thank you so much, Dr. Akhtari, for a great and invaluable presentation, and congratulations to your heart, full of kindness. Let's start the questions. We have the first question from Dr. Rezai. I have a question about the role of NGS. Dr. Rezai asked about the role of NGS to differentiate between hypoplastic MDS from aplastic anemia.
Oh, that's a good question. So, MDS, hypoplastic, aplastic anemia, hypoplastic MDS, and PNH have overlap. Obviously, until very recently, HLA-DR15 has been a great help to differentiate. If a patient is positive, you could think about hypoplastic MDS. About the role of NGS, I am not aware of actually. If there are certain changes or mutations which could help to differentiate these. I would like to refer to other colleagues who are present if they know, but I am not aware actually.
Thank you very much. Second question is from my teacher, Dr. Ashrafi from Isfahan University of Medical Sciences, The patient is a 72-year-old lady, presents with anemia and leukopenia. Bone marrow study is compatible with RAIB1. Cytogenetic study is 5Q minus. What treatment would you recommend? Lenalidomide or hypomethylating agent?
That's a very good question. I don't think, if you is RAEB1, I would use hypomethylating agent. I don't think lenalidomide is going to help, to be honest with you. The only thing is that, obviously patient is not a transplant candidate. Yeah, I would use azacitidine and 5 days in a row, 75 milligram per meter square daily, and every 28 days. I am worried that lenalidomide could cause more cytopenias, and transfusing the patient. Probably azacitidine would be a better choice here.
Also, my question: if you didn't have any response to azacitidine,
okay,
you use lenalidomide.
So, yes, that's a good question. You would use the lenalidomide. Yes, you could try, but there is, I would give at least 4 cycles. But if you don't see, I think it's a good choice. You could switch to decitabine, although there is data that those patients who you switch from azacitidine to decitabine, they do not have a good prognosis. But yes, I think it's an option. However, in my hands, in those patients, I haven't seen good response personally, but I might be biased.
Thank you very much. Again, a question from Dr. Rezai from Isfahan University. What is the role of MRI of vertebra for differentiating hypoplastic and MDS from apoplastic anemia? The role of MRI in differentiation.
Very good question. First of all, regarding Isfahan, I have to say I have good memories from Isfahan. My uncle is a retired pediatric hem-onc physician, Mahmoud Beheshti Zaware. So very good memories about Isfahan. Regarding MRI, I don't think I don't think you could. With MRI, obviously, you would see some abnormal findings, marrow signals by MRI, but I don't think you could differentiate. You look at the bone marrow, and then you and try to. So I don't think I don't think there is evidence, to be honest with you. I am not aware of evidence. You might say with just thinking loud, with aplastic anemia there should be no signal, and then with MDS you might see some abnormal signal. But for example, there is. You are right that with MDS patients, the bone marrow signal is abnormal, or AML or ALL patients. But I don't think you could differentiate based on MRI findings. I don't think so. You need to do the bone marrow and then even repeat the bone marrow, and then look, obviously, as I mentioned, HLA-D, looking at HLA.
Thank you again, Dr. Akhtari. Dr. Rezai asked, does using Gcse in high risk or intermediate risk MDS increase the risk of AML progression?
That's an excellent question, Dr. Rezai. I use G-CSF in low risk MDS, but in a high risk MDS, I think we should shy away from it, even in AML patients, because traditionally in US, wherever, like my mentors and I know my colleagues, we usually do not use it unless in because it would increase the number of the blast, and you would see in peripheral blood, and then you would be scratching your head that is this progression, or is it what is going on? Unless a patient is in the hospital, for example, has got fungal pneumonia and is neutropenic. If a patient is, in ICU and you are very worried that you might lose this patient, then, and the patient is pancytopenic, I would give a try. In that patient, I might use GM-CSF rather than Gcse. But generally speaking, I would shy away from using colony stimulating factor, granulocyte colony stimulating factor, Gcse, in intermediate and high-risk MDS.
Thank you very much.
Sure.
Next question from Mojtaba Akhtari. Hi everyone. Is there any difference in treatment of HIV patients that use ART and have therapy-related MDS?
No, actually, I would keep the patient on the treatment for HIV and then treat them. The only issue is that some, like in the US, if you want to take the patient to transplant, they might not, they do not accept. Many insurance companies do not authorize taking an HIV positive patient for an allogeneic stem cell transplant. They get disqualified. As you know, they are worried that in an immunocompromised patient, the HIV would get out of hand. But I would keep the patient on the HIV treatment and then treat it as the same as a non-HIV patient.
Thank you very much. Again, Dr. Rezai asked, what is the role of thrombopoietin TPO receptor agonist in MDS who has thrombocytopenia? Is it applicable? Does it work?
Okay, that's excellent question, Dr. Rezai. You ask very good questions. There is data. They have used it, thrombopoietin stimulators, TPOs, in MDS, low-risk MDS patients, and it actually, the data wasn't convincing. And there were some patients who actually progressed or patients who died. So in US, it has not got approval. The pharmaceutical companies tried hard to see if they could get approval, and it was never, it didn't get approved. So we don't use them in MDS.
Thank you very much. Also, again, a question from Dr. Rezai. What is the plan for patients with CHIP, ICUS, CCUS diagnosis and follow-up?
Okay, can you, sorry, I didn't get the short form. Can you tell me what exactly you are talking about?
ICUS, CCUS diagnosis.
Oh, yes. Oh, okay. Got it. So this is, there are patients who have, they become, they have either isolated cytopenia with uncertain significance or clonal cytopenia with undetermined significance. This is good question. Some of these patients would progress to full-blown MDS. I would repeat the bone marrow and send it for mutational analysis to see if you could see any changes. And so I have had patients who actually. So if a patient has clonal abnormalities, that patient is more at risk for progression to MDS. Should we treat them? I would wait on. I would look at the the blood numbers. If a patient is becoming like more anemic and becoming transfusion dependent, so it means that the patient is progressing. I would repeat the bone marrow and decide about treatment. But these are, this field is still evolving. And both ICUS and CCUS but interesting. I have a number of those patients that I'm following closely.
I see no any other question.
I enjoyed it, and I hope we will meet again. Be safe and well.
Thank you so much. Again, thank you so much, Dr. Akhtari, for your great and invaluable presentation. And also, again, congratulations to your heart, full of kindness.
Sure. As I mentioned, those are my contact details. I am happy to answer any questions or concerns. I give my cell phone number to my patients, so you are my colleagues. You know, by all means, if you have questions, let me know.
Thank you.
No question.
Okay, all the best. به سلامت به امید دیدار.
Our grateful thanks go to all who participated. Thank you very much. Have a nice time. Dr. Shadman, Dr. Yarmai, do you have any comment?
Are we going to have like a, do we get like a feedback or a bit of chit chat after the meeting, anything like that?
Thank you so much. Have a nice time.
All the best. Bye-bye.